Right, okay, so I'll get started. Well, look, thank you again for inviting me. My name's Keith Grimes, and I'm going to be talking to you today about the practical role of VR and AR in primary care. And I would have been there in person, but things happen sadly. So let's see if we can get on to the next slide. All right, so who am I? Well, I am a GP and I am a geek. I have been a GP for 15 years, but I have been a geek for much, much longer. I work in a walk-in centre in Eastbourne, which is on the south coast of England, and I specialise in urgent primary care. It's the sort of thing that you go and see a doctor about, but quickly, but not so quickly as needing to go into hospital. And all the way through my career, from medical school, through my training, and in my work as clinical lead in urgent care, I've always tried to use consumer technology to help me in my day-to-day work. So I've kept patient notes on my Scion, and then I kept it on my Palm Pilot, and then I've put it on my smartphones. And I've been a coder in my time. I've coded in JavaScript, Objective-C, even Visual Basic, all trying to automate my daily work and make it easier. And even in the last year, the team that I work with was awarded with a People's Choice Award from NHS Scotland for a project called My Little One. And My Little One was a project where we used off-the-shelf components, we used iPads and web cameras, and we produced a secure system to allow parents to see their children in the neonatal intensive care unit when they couldn't be there. And that started up with about a 6-month window to get going. It's been running for 18 months, still running now, so we're quite pleased about this. And all of these are really simple, cheap and practical solutions to the problems that I faced and I saw in my clinical work. So you can see why I think of myself as a digital healthcare innovator and as a frontline healthcare hacker, because my approach is to keep it simple, keep it cheap, and keep it practical. So I first became aware of VR back in the early 90s, maybe with some of you guys back there, introduced by the way of William Gibson's novel Neuromancer. And augmented reality, I reckon, came about earlier when I watched The Terminator, and we saw with the augmented reality there. Of course, back then there was no shortage of amazing ideas for healthcare and VR. I mean, there were brilliant ideas. It's just that the technology was really poor, didn't keep up with it. And so we're about 25 years later now, but it's no longer the case. I mean, this year we've seen the launch of the commercial versions of the Oculus Rift, the HTC Vive, and we've also got the Samsung Gear VR, we've got Google Cardboard. And the result of this is that now we're seeing a real public explosion in interest in VR and AR, and really big claims being made about the potential of VR and AR to help with new treatments for different conditions, from phobias through stroke rehab, even managing chronic and acute pain. And not only is the evidence base growing, but so is the actual use of VR. Now, I believe earlier on you might have heard about the work of Shafi Ahmed. Shafi I saw yesterday, actually. He's a surgeon based in London, and he did the live stream of a 360 video of an operation. And I saw him yesterday and stole a few of these off him, which I'll come back to a bit later on. And so thousands of people watched it, and you can imagine the benefits of medical training in hard-to-reach areas. Now, all of this is second. It's always expensive, it's always really high-tech stuff. That's where a lot of the money is spent. But it's not where most of the work is done. Most of the work is done in primary care. And that's where I work. Primary care is the engine room of healthcare. Primary care is the coalface. And in the UK, 90% of all NHS work occurs in primary care. And in 2014, to give you an idea of that, in England, 340 million consultations took place. All right, that's huge. And in the UK, in the same way as the Netherlands and most of the developed world, we're actually facing a number of pretty significant challenges. And that demand that I told you about, well, it's rising 13% in the last 6 years, running up to those figures. And there's no sign of that slowing down. Workforce is changing. There's a falling number of doctors. They're either burning out, fading away, or just retiring. Patients that we see, they're older, they have more complex illnesses, and the treatment is more costly. And our premises, they're old now, they're having problems, they're not up to the task. Then we've got the economic, and we've got the political issues. So we have the workforce striking, we've got the nurses potentially striking, ambulance drivers. In short, it's difficult times. Now, if you want to make a difference to global health, and I'm sure people here do, you need to do it in primary care. We need our technologies to help quickly. We need them to help in a simple, cheap, and practical way. And so how can VR and AR do this? Well, there are lots of researchers working on it, but my philosophy, as I've said already, is to use the available technology and partner with patients to deliver benefit as quickly and simply as possible. Now I'm going to describe a couple of projects that I'm working on at the moment to illustrate that. Okay, so I'm going to start by telling you about a patient I'm going to call John. Now, John, he's a great guy. He's in his 50s. Sadly, he's very overweight, and he loves rugby. In fact, he kind of loves rugby so much that he avoided seeing a doctor pretty much his entire life until his health got in the way. I've been helping him since then. And one of the problems that John has is chronic leg ulcers. Now, I don't know how many medical people are in the audience, so I apologize if I over-explain some of this, but leg ulcers can be caused by a number of things, but they require regular dressing. And those regular dressings can be very, very painful. I mean, John is a prop forward. And if he complains of pain, you listen to him because he's had a painful life. Now, he was having dressing changes 2 or 3 times a week for months at a time. And so one day he said to me, you know, Doc, I wish there was something that could distract me when they're changing these bloody bandages. And of course, at that point, I thought, well, yes, there is something that can distract you. There's my Samsung Gear VR. And so we already know from research evidence that the Gear VR, can be very effective at reducing pain, either acute pain or chronic pain. So I've started the process, and I'm in the middle of it just now, in trying to get him to use the equipment. I've had him try the headset. I've had him select some material to watch from the existing 360 videos out there. And as of next week, we're going to start putting it on him so he can wear it when he's having his dressing changes. And if that proves effective, I've got a presentation booked in already to demonstrate VR to the local wound healing center. And the wound healing center treat all of the patients in my locality who have chronic ulcers. And I'll be able to give them some cardboard headsets, again, cheap, easy to get hold of, and the patients can take them away. So this is simple, cheap, and practical virtual reality. I've got another patient. These are all genuine patients. I've just changed their name. Let's call him Mike. Now, Mike is in his 70s, and the problem for Mike is that a few years ago he was having angiography for his heart disease, but he had a very non-routine complication. He had a tear of the angiography site, and as a result of that, he sadly lost his lower leg. He had a below-knee amputation. And since then, he's been suffering from burning pain and cramping pain in his foot. Thing is, the foot's no longer there. And that's phantom limb pain. And again, some of you may know what this is, but for those that you don't, it's a very unpleasant complication, not that uncommon following amputations. Patients will experience quite severe pain, cramping, or burning in their missing limbs. And they think that it's due to the central perception of pain, and the reality for this patient, as well as many of them, is that you really cannot treat it with drugs, even strong drugs. Now, research has already shown, and Ramachandran back in '96 found that the simple discovery of using mirror therapy, where you place a mirror between the missing limbs, can actually significantly reduce pain and unpleasant sensations from the missing limbs. And that's been replicated in virtual reality as well. Now, if you look on the right side of the screen, this is a person, you can see here, a patient, and that patient's got what looks like just a slightly below elbow amputation, and they've got some electrodes on their hand. And this is from a study that was done showing that in this patient, the electrodes will simulate the movement of the hand, which augments the effect as well. So this patient who had serious, severe, ongoing pain had persistent relief of pain thereafter. So currently there's no off-the-shelf solutions for this, and so I've been in contact with people through some Facebook groups, and I'm working with some developers in the UK and the US to try and create some very simple intact body experiences, which I'm going to be able to work with Mike and share with him, again using Google Cardboard probably, so he can use it on his own and take it away. And he can use it at night, where instead of having his wife wake up and rub ice over his stump and massage his other foot, he'll be able to try this as well. So this is a simple, cheap, practical piece of VR. I don't want to say miss out on augmented reality, but augmented reality clearly has a role to play. Now, my feeling on augmented reality is that at the moment it's slightly stuck in terms of tablets and smartphones, which limits it a little bit. We've got HoloLens, Meta, and Magic Leap coming along, and they probably put us at the point now that we were with Oculus Rift about 2 or 3 years ago, maybe even more than that. As these develop, we're going to get much more immersive AR and mixed reality. And what I've been trying to do is I've been trying to look at my consulting room and think what it is about the consultation in primary care that could be helped by augmented reality. Now, if any of you guys have gone to the GP, you'll probably have the same thing that we do. You'll come in, and one of the major barriers is that you'll have a doctor, you'll have the patient, and then in between, you'll have a computer screen, sometimes literally in between. And that gets between them, that gets between you. And the other thing is you probably don't get to see what's on the screen either. And all of this hampers communication. I think augmented reality has a really important role to play there. I think augmented reality can provide a mutual space where information can truly be shared and develop a shared understanding of the information. So to that end, I'm currently working on 2 projects. Again, with local developers that I met yesterday in Brighton, in fact. But I'm also working with some of the big developers of the GP clinical systems. In the UK, there are 3, and one of them has got some ideas about innovation. So I'm working with them, and we're going to be putting the hackers together with myself and these developers. The idea is that we'll be able to key off a target image, a mouse mat in this case, and with a tablet, I'll be able to sit next to the patient and I'll show them using augmented reality 3-dimensional models of anatomy to give them not only a clear idea of normal anatomy, but be able to use some of the downloaded information from their scans so they can see their anatomy too. And what appears to be really powerful about AR and some of the test stuff that I've done so far with a non-medical side of things is the effect that the object appears in the real world really drives home the message far better than a flat screen might. And so again, through Facebook, through hacking events, I've met up with developers, and I'm able to put these simple pieces of technology in front of patients and get feedback straight away. And you may already know about these, but even in my own practice, I've started to keep a list of patients, and they're waiting for the applications to be available for them. So I have patients with social anxiety disorder. I think Manish earlier on would have told you about the Rico Theta 360. I'm thinking of being able to use that, and you have patients who are afraid of crowded spaces. Record 360, it's a much quicker way of getting a very realistic environment compared to rendering it in virtual reality. The distraction therapy that we're using for my patient John with the wound and dressing changes, we've got lots of patients with needle phobia that refuse to have blood tests. This might help them. We've got patients with stress, anxiety, and mental health disorders that would do well from mindfulness and meditation. And then there's patients that are isolated by virtue of physical or mental health problems, or even just frailty and old age. Social VR, like AltSpace VR and Oculus Social Beta, I think it's called. Those environments are useful for people to come and meet in a new way. And then the final thing that I'm actually quite excited about, and I've got an event on the 12th up at my local palliative care hospice, is that those patients that are frail, that are bedbound, virtual reality offers them the opportunity to travel the world and be freed up from where they are right now. So, great, fine, let's go ahead and do it. Except in medicine, we have to first do no harm. And so I'm going to be listing some of the problems that you're probably sometimes aware of, but it's worthwhile exploring a little bit more. The first is simulation sickness or VR sickness. I mean, this has been around since flight simulators, even before that. From a physiology point of view, it's thought to be a disconnect between what you see and what you feel. And we feel, or rather technologists, and I caught what was said on Periscope earlier on actually, so even things like foveated VR, all of these technologies will hopefully reduce that discrepancy between what you're perceiving and what you're feeling. And as a result of that, should reduce simulation sickness. And I was only just reading about it. There's not only technological approaches that way, but Mayo Clinic has developed something called galvanic vestibular stimulation, which uses stimulation to help synchronize movement with what's being seen on the screen to reduce the likelihood of simulation sickness. When VR works, it conveys a very realistic environment, and so patients may be exposed to distressing environments. In fact, sometimes you want to be doing that anyway when it comes to challenging them with their phobias. But some patients may have actually adverse effects as a result of that, and that's what we call abreaction. So, post-traumatic stress disorder, increased social anxiety, and even what they've described as reintegration trauma, psychological damage or harm caused to patients who previously missing a limb, seeing their body integrated again for the first time in some years. When it comes to infection control, I mean, I've been struck at how little attention is currently paid to the most basic hygiene and infection control. If you guys have been to any conferences, I don't know how often you've just been going up and putting on a headset and then passing it to someone else and then passing it to someone else. One person has conjunctivitis, they've all got conjunctivitis. Now, in healthcare, you can't just let that go. And so we have to develop good protocols and management. We need to get decent headsets. down on the bottom right, and I don't know if it's included for you, is a headset for a company called Opto VR. And they're doing a Google Cardboard style approach with integrated earphones. But what's really interesting about them is that headset is closed cell foam, which allows you to keep it very clean. And then there's falls and injuries. First time I used the HTC Vive, I smashed my friend's light because I was shooting things in the air. And that's me, I'm fine. But it doesn't take much to imagine an older person, a frail person falling over, breaking a wrist, breaking a hip, hurting themselves. I think that there are ways around this, but for now we're going to need some chaperoning. And then, of course, worries about security, confidentiality, equity of access, cost. These are all important. But the important thing is that we're facing such huge challenges that the appetite is there for a change. People are more willing to try risks. I mean, I consider myself an early adopter, obviously, but I'm seeing a much more appetite for innovative approaches in my colleagues and nurses as well. So if you want to be part of this and you want to help people, you're going to want to do it in primary care. And the other bit of good news is that there's actually money for this, at least in the UK. Last week, the GP Forward View, which was a 5-year forward view about the funding within general practice, was published. And this shows a commitment over the next 5 years to increase funding in primary care by £2.4 billion per year, an increase. And that was with an emphasis on improving workforce, premises, but specifically new ways of working and specifically technology. So there's a very sort of fertile environment, and there's potentially going to be money in there as well. And so my vision for VR and AR in primary care began with being a user, just like I'm sure lots of you. It's just really exciting. It's really interesting. It's fascinating what's going to be there. But it's much more interesting to know that VR and AR, they're not just tools that just replicate what we're doing right now, because in fact they probably get in the way of a lot of the things we're doing right now. It's actually much more interesting to think about the things that we can do better or differently. And so I appeal to everyone there today. This is my appeal to you. Speak with patients, speak with your doctors, speak with nurses. Get to know exactly what the environment is in primary care and what the problems are. We will happily share this back the way. Use the tools that are available to you right now. Simple tools like Google Cardboard, Samsung Gear VR, content that's out there. Get VR and AR in front of clinicians and patients. Experiment with what's going on. Do it in a safe way, and then share your findings with the wider community. Raise the profile. And then I think, in truth, VR's big time is possibly still a little way off. AR maybe even a bit further too. But I reckon it's going to be the public that are going to be coming to us, asking why we aren't joining them if we're not careful. And so, just as I wrap up and before I take any questions, you may be wanting to know how you can find out more. I've set up a Facebook group called VR Doctors. You're very welcome to come and join that. It's not just myself. There are other doctors working in here in the US. There's also developers and other interested parties. And there's a Twitter address to go with this. In the UK, there are organizations that can help you as well. The Academic Health and Science Networks are publicly funded. There are 15 of them around the UK or in England. And they exist specifically to bring together education, healthcare, researchers, and industry to foster innovation. And in Scotland, there is an equivalent called the Digital Health and Care Institute, or the DHI. And in fact, they're the people that worked with my team to deliver My Little One, the successful project that we've had. And of course, you've got your hack days. The NHS has its hack days. The next hack day is coming up, and it's on the 14th and the 15th of May, and it's in London. And it's free to attend, and I'll be there. And when I went to the first one about 18 months ago, there was one VR hack. The last couple, there's been 4 or 5. I do not doubt that there will be many, many, many more this time. And of course, you can look at my website. I try and blog about it when I can, when I'm not seeing patients. And I'm also on Twitter. And I'm always very happy to answer any questions and approaches and share what I consider to be the reality and problems of healthcare and primary care. And then just to finally say, look, I think we are standing on the brink of a really amazing new form of communication. And because communication is such an important part of primary care, we're standing on the brink of a really important new form of therapeutics. As the technology develops, I think the distinction between VR, AR, and mixed reality will go. And right now it feels a little bit like we've been inside a room and we've been interacting with the world through just a panel, through a square. I think VR and AR are basically allowing us a door to go out and step and see the outside world and be there and share it with patients. And I think that is the most amazing prospect of VR and AR in primary care. So, thank you for listening. I hope that wasn't too quick. I'm very happy to answer any questions and allow you to get out and enjoy Amsterdam because it is amazing.